everybody. Welcome to our Tuesday chat. I am Brenda Green with the Be Strong Group. My husband and I founded this nonprofit in honor of our son, Braden, who has sickle cell disease. And our mission is to spread awareness through advocacy, education, and empowerment. We wanted to come and bring to you via this Tuesday chat, this virtual discussion, a series of topics that are important to those with sickle cell disease as well as to their caregivers. And, a lot of the topics that we've covered over the past year or so has actually been applicable to everybody. So we're excited to have you. And we're super excited to have our special guest tonight. You probably heard of me talk about her, Dr. Carla Roberts, which is she is Braden's hematologist, and not just Braden's, but she care for a lot of the kids with sickle cell disease here in the Midlands. And we're going to have a discussion about sickle cell disease. And I want to, before we get started, that if you have any specific questions about your child's health or situation, please, this is for educational purposes only. And we ask that you consult your primary care physician or a specialist, even as Dr. Carl is your specialist. Let's, keep the questions general. So without further delay, we're going to bring to the stage Dr. Carla Roberts. Hey, Dr. Carla.
Hey, Miss Brenda, thank you for having me on this show. And I'm sorry that my background's not as pretty as Brenda's is.
Oh, you're fine. We know you're still at the office, so we
Yes.
appreciate you taking time out of your schedule to talk to us. And Dr. Carla, you're Pediatric Hematology Oncology at Prisma Health Children's Hospital Midlands. Dr. Carla, can you just share a little bit more to the people about yourself that you're comfortable with?
Yes, yeah. So I am Carla Roberts. I'm from South Carolina. I'm very fortunate to be back here working. Not working is my passion, what I'm doing, living my passion. But I am a pediatric hematologist oncologist, but have a very special interest in sickle cell disease, which is near and dear to my heart. And I've been here for 20 years. I moved here after I finished my training in Atlanta, and so I've been here for 20 years now. And we have grown from around 250 children with sickle cell disease to almost about 600 patients that we have now with sickle cell disease that we follow here, and as well as from the Midlands area, Orangeburg, Florence, and towards Newberry. We've have many pediatric patients, but also have several young adult patients that we're caring for now. And you'll see that's kind of that's actually been a trend across the country as we have many of these pediatric patients that are living these longer, healthier lives, and we don't have as many adult providers, and so many pediatric hematology oncologists are champions of these young adults, and adult patients are now doing what they call lifespan clinics. I'm not technically doing a lifespan clinic here, but we do have several young adults, so that's why we have about 600 patients. And so I'm very fortunate to have my partners that help share in the care of our patients, as well as our Katie Lethco, our nurse practitioner, and we have just a wonderful clinic staff, and our nurses and our psychologists, and some of them I know that y'all have met before through this chat. But so with these the sickle cell patients that we have, I'm not sure how many of you are familiar with the different types of sickle cell disease, but there are kind of four main types that we see in the United States. And sickle cell, before we delve into that, it's a hemoglobin disorder, and this is kind of just very basic, but hemoglobin that's inside the red cell to carry oxygen. And you inherit a hemoglobin gene from each parent, kind of like your brown eyes or brown hair. And there is normal hemoglobin, but there are hundreds of abnormal hemoglobins out there. And depending on what someone may inherit, may lead to a type of sickle cell disease or other hemoglobin disorder as well. So as far as sickle cell disease, though, the main type is what we call the SS type, where someone's inherited the sickle from one parent and sickle from the other parent. And about 65% of our patients have that. That's true throughout the country. About 25% of our patients have the SC type, where you've inherited sickle from one parent, and then hemoglobin C is another abnormal hemoglobin from the other parent. And then there are these types that are called sickle beta thalassemia, where someone's inherited sickle from one parent, and beta, we'll call zero thalassemia, where they aren't able to make any normal hemoglobin, versus sickle beta plus thalassemia, where they can make a little bit of normal hemoglobin. And about 10% of patients have that sickle beta plus or beta zero thalassemia type. In sickle cell disease, it's found on newborn screening. So we learn about this. We get to follow all these children throughout their lives. It's awesome. We get to meet them as infants and get to grow up together, because it is found on the newborn screens. That's how it's detected. And so some things that we with sickle cell disease, some things that we watch out for are effects of anemia, or we're learning more and more that sickle cell is not just a red cell problem. It's really an inflammatory problem, really a vascular problem. And so we'll touch on that in just a second. But as far as the anemia part, a normal red cell lasts about 120 days compared to a sickle cell that lasts about 15 or 20 days. So the sickle cells are always breaking down, and they can release the contents from inside the red cell to outside of the red cell that are not good for the bloodstream, not good for the environment. And so because those cells are breaking down prematurely, that results in the anemia. And one of those byproducts of the red cell breaking down is bilirubin, and that's what can sometimes make some people with sickle cell may have yellowish eyes or a little bit of jaundice, and that could be sometimes only the visible thing that you may see in someone with sickle cell disease. Those red cells, whenever they are going through the sickling process, they start off as being round, but then they can become misshapen, like a sickle or a crescent moon shape, and that can happen if someone is dehydrated or under extremely have overexerted themselves. Infection could be a trigger. There are various triggers, but anyhow, those sickle cells aren't as deformable as the round red cell is, so they can't flow through the little tiny vessels that as a red cell would, and so then whatever that blood vessel is trying to get to, that part of the body can't get the oxygen it needs, and it would start to hurt. And so pain is kind of the hallmark of sickle cell disease. So we have these, what we call these kind of vaso-occlusive, that's the tiny vessels getting clogged up, basically problems, as well as the hemolytic anemia, which is the premature breakdown of these red cells, that problem as well. But again, as I touched on, so we've learned, sickle cell, again, it's not just about the red cell. We are learning that these that the substances that are released from these broken red cells are very irritating and cause and can lead to inflammation throughout the body, anywhere that blood goes, which is everywhere. Inflammation. Also, too, you may have heard about white cells before, and white cells typically people think of as fighting off infection. Well, in some people with sickle cell disease, those white cells can be they're higher, they're increased, and as a mark of inflammation in their bodies. And so the white cells also contribute to the effects of sickle cell disease, as well as the platelets. Platelets you typically think of as these little tiny things that are in your blood vessels that help you make your blood clot whenever you bleed. Whenever you bleed, it helps you to stop bleeding. And those are often elevated in patients with sickle cell disease, just as part of this kind of inflammation that they have, and they can also contribute to the inflammation in the vessels and the irritation of the vessels. So as a result of us learning more and more about sickle cell disease, our treatment is changing dramatically, which is exciting that we have some new therapies now to offer patients. It used to just be, back in the 1980s, that's whenever we started screening for sickle cell disease, and we knew we needed to give start penicillin at a young age because people with sickle cell disease can be prone to infection. So we did the penicillin, and then that started those in the mid 80s. And then a little bit later in the 1980s, we started learning about hydroxyurea, which is actually, it's an old cancer drug, but like a lot of other medicines, it's found to have other uses. And for people with sickle cell disease, it helps to your body start making more baby blood again. And the more baby blood that you can get into that red cell, it's going to keep that sickle from sickling and going to that shape change. It's going to keep some rounder red cells. And in addition to affecting the red cells, it also affects the white cells and the platelets, because I said those are bad actors also. And so it helps actually to reduce the white cells and the platelets. So that helps to contribute to better vessel health and better and decreased overall sickle problems, less pain, helps protect from acute chest syndrome, stroke, kidney issues. It helps your oxygen level go up. It's good for the whole everything. So that was introduced in the 1980s and FDA approved for adults. Then it got some FDA approval for children more recently. But we had nothing for, let's see, that was in the mid-1980s. In 1986, it was approved, 96. So for 25 years,
Right.
until these past 3 or 4 years, we've got 3 new medicines now for sickle cell disease, which is super exciting. And there are more in the works. And so these, the one of the new medicines is called Endari, Endari, which is the brand name for L-glutamine. And L-glutamine, it's a powder that you mix with something to drink twice a day. It's approved for 5 years and older, so for children, teenagers, adults with sickle cell disease. And it basically kind of acts as an antioxidant inside your body. And it helps to keep the red cell count more stable, and thereby help to reduce pain crises. So it's found to have result in about 25% reduction in sickle cell pain. Now we do see some people complain some stomach upset when they take the medication, so that's been prohibitive for some people from taking it. But most people that take it, they tolerate it fairly well, and I think they feel like too that it's some people. You can take that with hydroxyurea. Some people may choose that over hydroxyurea because they feel like it's kind of more natural, maybe since it's an antioxidant. And so that was the L-glutamine, and then that was approved in 2017. And then in 2019, we had two other new medicines approved. One of them is called Oxbryta, which is Oxbryta, and that's the brand name for voxelotor. And so this so before medications are given a name, they're given like a GBT. That was the company that made it, 569 or 467, because they tried 467 times, the scientists did, to find something that would work. It's pretty often. So people, it's pretty pretty awesome, the research that goes on behind the scenes that we're so thankful for scientists doing this, and then for patients to participate in these clinical trials, so then it can get out to be used for we offer for everyone else. But anyhow, they tried hundreds of times and got it right. And so what this does is they created this molecule, this medicine just for sickle cell. And so so inside your red cell, you have all this hemoglobin hanging out inside of it. And the sickle hemoglobin should want to hang out by itself, but sickle hemoglobin likes to all stick together, which then results from that round shape to the sickle shape. So this molecule, it binds to the hemoglobin. It is something you take by mouth. It's 3 pills a day. They're working on some suspension now, but it binds to the hemoglobin and to the sickle, and so therefore the sickle keeps the oxygen on there, and so the sickle can't all stick together, so the red cell stays healthier and rounder, and so doesn't have you don't have those downstream sickle effects. And so again, this one's approved for 12 and older. It's 3 pills a day. It's being tried in younger patients now with a suspension, but that's those trials are ongoing. And it helps to increase the hemoglobin by an average of 1 to 1.1 points within 2 weeks of taking it, and stays up that way. And I actually just read an article. They've now they've followed these patients for about a year and a half who've been taking the voxelotor or the Oxbryta, and they're still having that sustained result, that hemoglobin being up higher. So, people might say, what's the big deal if a hemoglobin went up by 1 gram by 1 point. So most people, their hemoglobin normal for an adult or a teenager or an old child would be around 11, 12, or 13. Some people with sickle cell can live with a hemoglobin in the 6s or 7s or 8s. And so you can imagine sometimes that, just more tired, maybe, poor energy level and things. And so having that hemoglobin go up by 1 point can make a huge difference.
Mm-hmm.
And what we're now seeing, from these kind of longer term of effects, people taking it for a year and a half, we're starting to see some of those good downstream effects, like people are having less pain, reporting, just feeling better, improved kind of their quality of life. Taking this medicine. So that's Oxbryta. That was the second one. That was, or actually our third FDA approved medicine. So we had hydroxyurea, then we had the Endari, and then the Oxbryta. And then about the same time, Oxbryta was approved, a medicine called Adakveo, Adakveo. That was approved. And that's is the brand name or something called crizanlizumab, which is a mouthful. But again, this is something created that was specifically for sickle cell. And so, we talked about a little earlier about how sickle cell is kind of more of an inflammatory problem and a blood vessel problem. So inside the blood vessel, you have your white cells, and your platelets to help make a blood clot, and the red cells. And so there's this thing called P-selectin, which is this little, it's like an attachment to the outside of cells. Well, it is overproduced in people with sickle cell disease. So this P-selectin, it makes like the white cells stick to the red cells. It makes the white cells stick to the blood vessel wall lining. And so by knocking out that P-selectin, those cells can't stick together as much, and therefore everything keeps flowing better, and given the red cell can give oxygen whatever it needs to get to. So there's less of that clogging up and less vessel irritability. So this medication, again, another one's created and found for sickle cell, and so it blocks that P-selectin. So things flow better, and people have had decreased pain and acute chest syndrome, but decreased pain by about 50% in the patients that took the Adakveo versus those who did not. It's approved for people who are 16 and older currently. It's being studied in some younger patients, and we recommend that for patients who have had more lots of pain or acute chest. It is IV, and we give it here in the clinic. The first 2 doses are 2 weeks apart, then you go just once a month. And so we've got some patients now who've been coming in for over a year or so every month for their Adakveo infusion. And most people tolerate it pretty well. We've had some people who have sometimes had more pain while they're taking it, or some nausea, vomiting, and they stopped the medication. But we have some who have been taking it and feel like they've seen a great benefit in decreasing their pain crises and their hospitalizations. So it's super exciting. So so we now have 4 medicines, but 3 just in the past couple of years, that have come out, and there are more in the works that are being worked on. So it's super exciting.
Yeah, so I think I got them all. We have hydroxyurea, correct?
Yes.
Endari, Oxbryta, and how do you pronounce
it? It's Adakveo.
Okay, see, spelling is fundamental.
Yes. And then they're because all these drug companies are now, thankfully on board with sickle cell and producing these medications. You should go to their websites, the Oxbryta and Adakveo websites.
Mm-hmm.
They're for the drug company, and you can learn a ton about sickle cell disease. They have all these handouts and pamphlets and things, and are really trying to. They've put a lot of money into advertising,
right?
Which is not what we do this for, but it's good for patients and for families. Some people just want to learn about sickle cell disease. They've got some celebrities that are backing them and doing some commercials and things for them.
Yeah, and I think Dr. Anderson out of the
Mhm.
Prisma Health Greenville office will be speaking, and I'll share that on our Facebook page at a event hosted by the James R. Clark Sickle Cell Foundation. I think it's later this month, so I'll get the right
Mhm.
date. So
Mhm.
I think there's a lot of excitement around that medication as well. Yeah, right. Okay.
Yes, yeah. Um, and so I guess I just thought there's as far as some other new treatments. A lot of people may have heard about. Well, just want to make sure people that understand there is a cure for sickle cell disease. I think that's a kind of a misunderstanding out there. Some people say there's no cure, but there is a cure with a bone marrow or stem cell transplant. That's just not widely available for everyone because you have to have a good donor, and it's a pretty very big deal process to go through. But there is a cure. But because it's not everyone has a donor, and something to be a little gentler on the system, or is gene therapy. And so those trials, they started off in Europe first, but now are doing this in the United States. There has been a temporary halt in some of them because of some side effects, but we anticipate learning from that, and hopefully those will pick back up again. But for gene therapy, you basically you put in a modified kind of hemoglobin that's going to kind of take over the sickle cell gene from being made as much. And so those are ongoing now as well.
Okay. Well, that's great.
Yeah.
So that's a lot of information, and I'm happy for everybody who's listening. Now we have Dr. Carla Roberts. She's a pediatric hematology oncology here at Prisma Health Children's Hospital Midlands, and she's educating us tonight, talking about sickle cell disease. She's already mentioned she treats close to over 600 sickle cell patients, um,
Near 600, yeah.
near 600
Yes,
sickle cell
yes.
patients, children who come to here in the Midlands. So we're happy to have us. And if you have any questions, please leave them in the comments. And Dr. Carla, I do have one question. I know you said
Mhm.
you treat nearly 600, and I
Mhm.
know you touched on the age, but can you just share again with us how old some of your patients are?
We have several young adults, and we we that's because, and this is a problem again throughout the country. We're trying to build the more adult hematology oncology trained folk or hematology trained folks for sickle cell disease, and because again with all these new medications and our new treatments that we're doing, we have people living very full
Mhm.
lives, and in pediatrics we've always kind of worked together because it's a rather small community, pediatric hematology oncology, to do clinical trials and things. And so we've worked worked as a country together, and have all these successes and want this to be carried on to the adult world.
Right.
But in pediatrics, like some parents were pretty protective of our children, of our babies,
Mhm.
and if they're not going to get that same level of care in the adult world until we have some more adult trained folks, then many of us in the pediatric world are hanging on to these young adult patients. So we have several into their 20s. And now, if though they're going to, after they finish school, and if they are, depending on what's going on with their lives, where they may be working, living, getting married, having children, because we can't have, any, no, we can't take care of if they are, pregnant or married, we discharge them, transition to another adult provider. Um, but we have many young adults, about
Yeah.
100 plus, 100, 18, 100 plus that are 18 and older. But it's actually been nice to watch, to grow up with these young adults, because sometimes especially when you're younger, a lot of people do what their parents tell them to do. In the
Mhm.
teenage years, you're challenging, not just with sickle cell disease, but with everything.
Right.
These damn teenage challenges, and then sickle cell disease can compound that, and maybe not wanting to take a medication, or not wanting to because you may um, I try to tell patients that who go through those phases, people don't, unless you tell them, a lot of people, you can't tell you've got sickle cell disease on the outside. But I bet there are other people in your school with you who you don't know what's going on with them on the inside either, because they
Right.
may have, asthma. There's so many, illnesses and things, and many of us, many of us have something wrong with us, and you
Mhm.
just can't tell it from the outside.
Right.
And so, so some of those teenage years can be a little rocky for some people, but then it's nice to watch when the brain starts to develop more in your
Mhm.
early 20s, start to get it, start taking my medication again, start taking care of myself. And if they had not done that as well in their teenage years. So it's been nice to watch the, kind of evolution and maturity in these young adults.
Right. And I don't know, for those of you who are listening now who may have missed the beginning where Dr. Carla was sharing a little bit more about her career, she mentioned this is her passion. And I tell you, this mama, who she's been
Mhm.
seeing Braden since he was 3 months old, and he's now 15. It touches my heart because, and I believe, I mean, we live every word of what she's saying. This definitely is her passion. So, again, thank you, Dr. Carla, for being here. We're so grateful to have you. And I know you touched on a word, transition. That I'm in a position
Mhm.
of a child, we have to prepare. But what is your recommendation on how we can help our kids? There's a question that I received: be more responsible for their health and help
Mhm.
during this transition period
Mhm.
to adult.
And yes, and whenever we've there are some great transition sites out there. One is called Got Transition,
Mhm.
and but because we've not done a very good job of this, because we've not had a robust adult group to transition to, just like again many other places in the country. So we've not been as diligent with following that Got Transition, the recommendations, but the according to that, the transition process should start, 8, 9, 10 years of age.
Mhm.
But I try to, we give at the end of our visits, we give these a synopsis to our parents. But then whenever the child becomes a teenager, I try to have them come over and look at their end of the visit kind of summary and go through things about themselves and try to ask them more questions. But I think that when they're the teenagers, they should start calling the pharmacy themselves and get their request to learn how to call in their own medication or request a refill. And a lot of it's automated now, so that that's taking some of
Oh,
that
that's
away.
yeah.
Yes. Whenever we get back to having camp again, letting your children go to camp and go away, because many of these, some children never go away from home because of, for fear that something, if they got sick while they're away, or many of these children also they wet the bed because you can't concentrate the urine as well, and so there's people don't want to go somewhere and wet the bed, but at camp, so allowing children to leave and to go to camp, because at camp we try to focus on out there just learning how to live responsibly, play responsibly, and but still and take care of yourself responsibly. So that teaches an independence for the children and teenagers, as well as the parents letting go that week. And hopefully we'll get back to camp maybe summer 2022.
I
Hopefully,
know.
I miss it. It's a beautiful week every summer. Um, so, and then we also have a teen support group as well. So if and sometimes they go on overnight trips, or but so letting your children do some things, if you especially there'd be a medical team there with them, and people that you knew from the clinic, that may provide some comfort. And then and so sometimes on those teen trips, or since at camp, sometimes we play like the game of life. We've done that before, where we trying to teach people about their like insurance and about genetics, about how things are passed on. So we've since played the game of life to try to teach children or teenagers.
Right.
But I think them, I think make just some little things like having them call in their medications, know what type of sickle cell they have, what their baseline hemoglobin is, if they ever, and and then letting them go away if there was a trip, especially like camp or to a teen group or something like that.
Right. And you mentioned camp, and here we have Camp Virgin. And I do remember I was one of those mamas that wanted to keep the babies too, but I don't. Nurse Julia, I remember one of when we came, and Nurse Julia was like, "Have you filled out the application for Camp Virgin yet?" And I was like, "No, not yet." She's like, "It's okay. Here's your application. Look here and complete it." And I'm so grateful she kind of gave me that nudge, because he absolutely adores Camp Virgin, and it's so unfortunate he has had to miss the last couple of
3
years of
years,
eligibility.
yes, yeah.
So, but we have the team camps, and he's been away for 2 of those, so that was good, and we're looking forward to those starting back up again.
Yes,
Too.
yeah.
We do have a couple of comments that came in. One says, Dr. Roberts, can you share suggestions on how patient advocates can support sickle cell patients and families? Any ideas on how advocates can help support?
And I don't know if they mean as an as an organization or an individual. As an organization, you could, or as an individual, you could join like a local, if there's a sickle cell like foundation to either be on their board or to participate in the events. Maybe partnering. I know you partner with trying to do blood drives and things, but trying to get involved with a local Red Cross and trying to raise awareness for the need for blood donations for sickle cell disease. There's also too there's been a shift in how we do our kind of studies and clinical trials. It used to be so much driven by by the scientist, by the doctor, and thinking the doctor knew best, or the team knew best what the patients wanted. But now there's with many of the clinical trials that are ongoing, and Dr. Anderson will speak to this whenever he is on. But now we're through the National Institutes of Health and American Society of Hematology, we're now involving families and patients. They're part of all these clinical trial teams now, because we don't always we obviously don't always know best, and so that has been a big shift throughout all of medicine to involve the people who we're actually treating and their families, and to get input from them. Other things, right now with COVID, it's been difficult because we've since had volunteers that come to the hospital to visit or to play games and things if a child's hospitalized. Right now with COVID, that's we've had to cut that out for right now, but hopefully that'll change again later. And then maybe I was gonna say if you I was trying to think of somehow if you could go into a school as a patient advocate, but then you would have so I don't know if that would be possible actually, but maybe joining up with there's a sickle cell foundation, or hearing about groups like yours, or going to your the local Red Cross, and because there's always a huge need for blood, to see how you could go about partnering with them to raise awareness and maybe meet patients that way.
Yes. And I'm glad you said the Red Cross, and as you mentioned, that's one of our initiatives, is to support and educate the blood donation, and especially in the Black community, because we definitely need a diverse blood supply.
Right. I think, so these, patients with sickle cell, some of them are on chronic blood transfusions we have about 40 children with sickle cell who've either had a stroke or at risk for stroke. And so they're on chronic, they come to the clinic every 3 to 4 weeks for a blood transfusion. And many of the donors in the United States are white of Northern European ancestry and have different red cell identifiers than many of our sickle cell patients, who most of them are African American, certainly not all, but there's a difference in the Northern Europeans red cell and African American red cell. And so we give this specially matched blood. They'd match it, of course, for like for your A, B, or O blood type, but we do even more extensive matching, and so that's why it's so important to try to get more African American blood donors, because there's a better chance that that's going to match with one of our patients with sickle cell disease. Because we have, again, we have these 40 children that come every 3 or 4 weeks who are relying on people to donate and give them blood. That's to help them from having another stroke or have a first time stroke. And then also, episodically, people may need transfusions, like if for acute chest syndrome, or if someone's get really anemic from a viral infection or something, or spleen getting big. So there's times when people with sickle cell need episodic transfusions throughout their lives.
So everybody who's listening,
Yeah.
you've heard it from the doctor yourself, that the need is real. The need for blood is real. So those of you who donated blood at our last blood drive in August, end of August, we're eligible to donate again on October 23rd. I'm signed up. And then we're hosting another blood drive on December 28th to get another blood drive in for the year, because our goal was to host a blood drive once a quarter. So that will make our fourth blood drive of the year. So thank you, Dr. Carla, for sharing the need of that blood. It's important. Like we say all the time, blood is love and blood is life. So let me check my other questions on the side. Um, so I think we answer more of that. There's another one in the comments, Dr. Carla.
Yeah.
Says, do those with sickle cell have to take any special precautions when it comes to taking various medications or vaccinations?
Okay. Yeah. So as far as medications, um, precautions would be sometimes people with sickle cell disease may develop kidney disease, and so if that was the case, we would not want them to take anything like ibuprofen or Advil or Motrin, medication that could also affect your kidneys. So in those situations where we have people with kidney disease, we recommend they not take any of those medications. And we start around 5-6 years of age. We start checking a urine sample once a year for early detection of kidney disease. So then we get our patients, so they can be referred to the pediatric nephrologist, and they'll, even though the blood pressure is fine, they often start actually a blood pressure medication that helps protect the kidneys. So that would be something that we would say to avoid. As far as vaccinations, actually there are none to avoid. We need more of them. So with sickle cell disease, the spleen, which I kind of tell people it's underneath the left rib cage, and I'm explaining it to new parents, and it's kind of like a garbage disposal for your body. It helps you get rid of infection with and these certain bacteria that have a capsule around them, as well as like old red cells and just kind of junk in your body. It doesn't work quite like it's supposed to in people with sickle cell, and that's what it starts not working in infancy, which is why we they start taking penicillin. Children do in infancy to try to prevent one certain bacterial infection, but should definitely get all the routine childhood vaccines starting at 2 months of age, or really at birth with the hepatitis B, within 2 months of age with their routine childhood vaccines. But then we give some additional vaccines in the clinic that provide protection, extra protection against those bacteria that have a capsule around them. And then we give some extra ones, and then the meningitis vaccines, which a lot of teenagers get, we get that at a younger age in people with sickle cell disease, because their spleens aren't functioning very well as well. And so we start those vaccines at the age of 2, the extra ones. So yes, need all basic vaccines and plus extra. And then of course we do recommend the COVID vaccine strongly. It's approved for 12 and older right now. Hopefully we'll have approval for 5 and older soon. But the COVID vaccine we highly recommend.
And I'm glad you reemphasized that. I know we had Dr. Burke earlier who spoke on that and the importance of having that. And everybody who follows Brenda Green or the Be Strong group know that we vaccinate over here. So we want to do our part. As a parent, my husband and I, as parents of Braden, we want to make sure we're proactive and we're doing the best we can do to protect him, to make his journey as better, as good as possible, for his care. I see a couple of comments in there. You have Mr. Swanier, he said, good evening. She's been
Oh,
to a doctor for a little while.
yes,
So
yes,
shout out.
yes. Well,
Yeah.
hi to the boys.
Yeah, and Danielle Washington, she says, I can't wait until Tyson can experience going to camp.
Yeah.
Yes. Oh, he will love it, Danielle. I can't wait until they're able to go back. And then Danielle had another question, had a question. Is factor seven common in sickle cell patients?
Factor 7 deficiency. I guess that's what they.
Probably so.
Okay. So factor 7, that's your, a clotting factor that your body makes, and there is no relationship to factor 7 deficiency, because if you're deficient in factor 7, you can be prone to bleeding. So sometimes people have nosebleeds. Women may have heavier periods. You may bleed after surgery, and there's no association with sickle cell disease, but we have by happenstance found a few patients to have factor 7 deficiency because many of our patients have sleep apnea or may have gallstones or may need their spleen taken out. So we do a little bleeding screening test prior to any surgery, and we'll often find a something called a PT, which is a marker of how your body clots, that a little bit elevated. That's not uncommon in people with sickle cell disease. But when we see a little more elevated than expected, then we delve further. And we found about 5 patients who happen to have factor 7 deficiency in addition to sickle cell disease, not related, but just we did, and we had to take extra precautions for surgery. But there, and I'm not sure that's what the question was, if they would meant factor 7 deficiency, but
He said yes.
yeah. So no relationship, but it can be an incidental finding, just like, so that's what I was saying earlier, you can't tell how somebody looks on the outside always. There could be lots going on the inside that we're not aware of about each other.
Right. Absolutely. And I'm glad you mentioned
Mm-hmm.
that because, we hear that a lot. And, there's not always a evil intention behind it. But some people say,
Mm-hmm.
oh, it looks fine. Like,
Mm-hmm.
well,
Mm-hmm.
there's a lot going on inside that you can't see. And as you mentioned, that's the case with a lot of
Mm-hmm.
different people as well. And I know you mentioned some complication, and I know you said pain is associated.
Mm-hmm.
It's one of the most popular.
Hallmark of sickle cell. Mm-hmm.
Yeah.
Mm-hmm.
Can you mention some things that that kind of stand out a little bit?
Yes, yeah. So pain is kind of the hallmark of sickle cell disease, and being the most common problem for all ages, all types of sickle cell disease. But there are other issues as well, because anywhere blood flows, that could be a problem. And so kind of going from the head down. So some patients are at risk for strokes with sickle cell disease. And so we now do transcranial Doppler ultrasounds, or we call TCD, starting at the age of 2 in children who have the SS type sickle cell disease, and see if they're at risk. And with that technology, we have found more patients who are at risk and start blood transfusions and/or hydroxyurea, and have significantly reduced their risk of having a stroke. So here and across the country, we've seen a significant decrease in strokes. So it used to be about 11% of children around 5-6 years of age would have a stroke. We don't see nearly that number anymore. Thankfully, with this, since we do these screening ultrasounds now, we also can sometimes see changes in the eyes. It's called retinopathy, where the little tiny vessels in the eyes can kind of be clogged up, and then your body tries to make some new vessels around the area that was clogged up. And so we recommend going to the eye doctor between 8 and 10, around 8, 9, 10 years of age. Start going once a year. I touched on sleep apnea, since the tonsils and the adenoids can be bigger in patients with sickle cell disease, and can cause obstruction whenever somebody's sleeping. They may snore a lot, or and seem to have trouble breathing at night. And so many of our patients have seen the ENT doctor and have had their tonsils and their adenoids taken out. And usually feel a whole lot better afterwards, and which can also improve their oxygen level as well, and decrease sickling. The lungs, there's something called acute chest syndrome. It's kind of like a pneumonia, but that people with sickle cell can develop, and so we would check for that with a chest X-ray if we suspected that. Sometimes people with sickle cell can develop what's called avascular necrosis or osteonecrosis, which is where in all of us, our hip bones have poor blood flow for all of us. That's how we were born. And then if you add sickle cells on top of that, that are clogging up those tiny vessels, then the hip bone may not get the oxygen it needs, and it will start to deteriorate a little bit. And so we can see that sometimes. I mentioned gallstone surgery or gallbladder surgery earlier. Since the sickle cells last about 15, 20 days, they're breaking down always and releasing bilirubin. And sometimes over time, that bilirubin can clump together and make a gallstone. So sometimes teenagers or adults, when they need to have their gallbladder taken out, they start having symptoms of gallstones. We don't see this much in children or teenagers at all, but some people can, as adults, may have leg ulcers, and just kind of poor, like a person with diabetes may have from poor circulation. And then I mentioned earlier that we screen for the kidney issues, and sometimes we have to check for heart issues as well. So blood flow everywhere. But fortunately, we've got this hydroxyurea that's helps everything, and then we've got these 3 other new medicines that are out there that people can take in addition to hydroxyurea or alone, and there's more coming.
Right. And you mentioned, with all of that, and we actually have someone who actually spoke before about patient advocacy. I think she's still listening in, but she described it as when you have a child with chronic illness, you have a team. And like you're a part of our team. And we have, like you mentioned, there are several specialists and maybe the pediatrician and everybody in order to, and you mentioned a lot of times now, sickle cell patients can thrive. Your pediatrics are thriving now because of the new medication, more knowledge and education on how to treat them. And don't you recommend, it's the caregivers' involvement and education as well.
Absolutely.
Sure, we keep that team together and everybody communicate. That's how we try to run things here. So do you agree with that?
Absolutely. Yes. Absolutely. And in pediatrics, it's because I think we're pediatrics and we're tend to be nice people. Everyone in pediatrics communicates very well amongst the specialists also. Like it's very easy for me to call a Dr. Birch or to call someone if I need help, and vice versa. So we all work together for these children.
Absolutely. And you guys, I'm Dr. Carla. Sorry, I'm going to rave because as being an advocate and having a nonprofit and speaking to other people in other states and maybe even other countries, this isn't always the case of what you're describing as everybody being involved and communicating and all the a hematologist or a specialist who describes this as her passion. That's not something that everybody has, which is unfortunate, but that's one of the goals of being an advocate is to make sure we do our part in spreading awareness and throughout our country and throughout the world to try to get everybody on that level or close to that level. So again, we appreciate you being here, Dr. Carla. We appreciate you taking time out of your schedule. I know you've been there all day caring for our sweet babies, but you took time out to talk to us and help share information with our listeners. And for those of you who are on replay, you can still put your questions or your comments in the comment section. I will send them to Dr. Carla to get her response and share them with you with this video. Dr. Carla, I think that's all of the comments we have tonight. But is there anything in addition that you want to share that we may have left off? Anything you could think?
I don't think so. I'm appreciative of you asking to do this and for you doing what you do, and for all of you who are listening or watching to help us to continue to that. I'd love to not have a job, but we keep working together and keep helping these babies grow up and look at there, Miss Willie, to live these very full lives now, because it's pretty exciting, the changes that we have that have been happening recently and that are coming.
All right, and we thank you, and we got a lot of thank you, Dr. Carla.
Yeah.
and you probably recognize some of the
Yeah.
names. And taking care of our babies. Yes, we always love Dr. Carla. Yes, we're laying it on. But again, we appreciate you. Thank you everybody for listening in. Um, we try to come at least every other Tuesday, but this is a good one because we're coming up next Tuesday, and we're actually going to have a warrior circle. So we're going to have a group of adult sickle cell warriors who are going to come on and talk to you and answer your questions, share their stories, so we can continue with spreading awareness. So again, Dr. Carla, thank you so much,
Thank
and
you.
good night, everybody. Thank you for joining
Bye.
us.